We are thrilled to have you to join us today in this wonderful session. We have a packed and purposeful agenda and featuring some of the brightest minds in the Nigerian healthcare, law, administration, and policy. Today, we are gathered to tackle some of the most pressing issues, and we'll call on Mrs. Chinyere Okorocha to give the opening remarks.
Thank you so much, Toby. Good morning, ladies and gentlemen, colleagues, sector leaders in healthcare professionals, policy stakeholders. Welcome to this webinar organized by Jackson, Etti, and Edu. I'm very delighted to welcome you here. My name is Chinyere Okorocha. I'm the co-head of our health and pharmaceutical sector, and I also happen to be the public relations secretary of the Healthcare Federation of Nigeria. So that intersection between law and indeed healthcare is not new to me. So on behalf of my firm, I am delighted to welcome you all to this very important and much needed discussion. Defending your practice, legal, ethical, and operational strategies for Nigerian healthcare institutions. So today's conversation is not just about compliance or, sticky regulatory boxes. It's about the survival of our healthcare industry. It's about credibility and it's about sustainability in a rapidly changing healthcare landscape. And as many of you know, it is important that healthcare institutions have a sustainable structure in order to deal with the myriad of challenges that occur in the territory where we reside, which is Nigeria and ultimately Africa. So today, we're going to be looking at things like data breaches, which can result in not only the loss of trust, but also legal penalties for your organization. We'll look at medical errors and of course, negligence, and see how you can avoid such challenges. Operational weaknesses are also things that we'll discuss today to ensure that you're able to sustain your optimal services to your clients, as we call them in law, but your patients, and get the medical outcomes you want. But beyond all these risks, that we will discuss today, I really think that there's an opportunity for us to raise the standards in healthcare when we actually know how to go about it, how to put the structures in place, legal and regulatory structures that ensure that we are able to practice efficiently, raise ethical standards from the top to the bottom, and also aiming to strengthen operational systems. So this webinar today that you've been invited to will explore all this and more, practical strategies that will enable you give your best to your patients. We're going to hear from a group of experts today, and we're so delighted to have the creme de la creme of the healthcare industry in Nigeria come here to speak to us from their practical experience on how to tackle all these issues. We are healthcare leaders and professionals in their own right. And so I want to invite you all, whether you are running a public hospital or you manage a private practice, whether you work in healthcare regulatory or in pharmaceuticals, we all actually have a part to play in building the healthcare institutions that we really want, the ones that are credible, the ones that are trustworthy, and the ones that are built to last. So once again, I welcome you warmly on behalf of Jackson, Etti, and Edu, and I encourage you to make this more of an interactive session where you ask questions, where you participate, and at least you leave with at least one strategy that you commit to implementing in your own institution or your practice after the event. Because the true measure of this conversation is not the issues we raise, is whether we're able to take back something and actually implement it, effect positive change that can move us all forward and strengthen our institutions. So thank you so much for coming. Thank you to our speakers, and let the conversations begin. Back to you, Toby.
Thank you, Mr. Okorocha, for that poignant introduction. For that, now it's time to hear from someone who is no stranger to the healthcare challenges, victories, and healthcare leadership. So we'll call on Dr. Raymond Abiodun Kuti to share a keynote address.
Yeah, thank you very much for the opportunity. I believe we can all hear me.
Yes, sir.
Yes. So sorry, if I could just introduce briefly Dr. Kuti. He's the president of the Guild of Medical Directors, a consultant radiologist and chief medical director of Prisms Health Limited. He is a former vice president of the Nigerian Medical Association, Osun State Branch. He serves on the board of the Cerebral Palsy Center, and of course, he's a member of the American College of Physicians, Radiological Society of North America, American Institute of Ultrasound in Medicine, and the Harvard Medical School of Postgraduate Association. Please take it up, Dr. Raymond.
Thank you very much for the introduction.
Thank you.
And I want to thank everybody for attending, and then the organizers for this. I think what I just want to say at the keynote is just to probably tell the journey an average doctor takes in his lifetime, and how he reasoned along the way. And I think I'll probably go a little bit historical. In the medieval days, and probably during the Victorian days, it was the king that owns the land. And the other peasants are just there to live and use the land and pay rent. But as the time was going on, they started giving some group of people the ability to own the land. And they call those people noblemen. 4 main groups were taken there. We have the military men who had gone to conquer for the queen or the king. We have the lawyers, who are the learned men. And then we have the men of God, the spiritual advisors to the king. And then we have the medical doctors, who are also choosing to be the noble ones, the noble men. So that's why they call the law and the medicine noble profession. And 3 major things make every noble man be what they are. The characters and the characteristics they should have. They should be men of integrity, they should be men of honor, and they should be people that can be trusted. These are the 3 pillars which make the noble profession be what they are. And then let me quickly fast forward that to when a medical student gets into the medical school. At the medical school, those 3 main things are usually drilled into your brain. That you are in a noble profession, you must be a man of integrity, you must be a man of honor, and you have to be trusted by your patient. And that goes on, and I think that is not bad enough or good enough. They will always tell you your patient is the primary reason why you are a doctor. So you are made to be focused totally on your patient. So you become what I can call a patient-centric individual. So all your life, all your thinking is, this patient must be due and must get the best from me. And the other thing they push into your head is what the Latins will say, primum noc nocere. That is, please first do no harm. So and as a doctor, you have been taught that you must do no harm to your patient, and your patient must be your primary person to attend to. So you get into the society after becoming a doctor, and you have 2 options. It's either you say, okay, I want to work for government, or I want to work in a private hospital. Working for government is beautiful. You get to there, you see that, oh, the governance system is not fantastic. The protocol system is not fantastic. Even by the time you get there, the interdisciplinary and interprofessional rivalry is extremely bad and toxic. Then we have a situation in which, oh, the infrastructure needed are not working as they should be. So hey, you have to give your best as a doctor in an environment that's not conducive for the best you have been trained to do. And if you are fortunate enough to work in a private setup, we are okay. The conditions of the protocols are good, the structures are good, the systems are good. Most of the things you may need to work are functioning well. You realize that you do not have your life to live. Nobody takes into consideration your physical well-being, your emotional well-being, and your mental well-being as a doctor. And of course, that's the way an average doctor lives in Nigeria and the way he practices. And then, of course, because you have been tutored and been tailored that, yes, you have to do the best and give the best to the society and the patient, you are very regulated as a doctor and a practice facility. And I can tell you as of now, we have about 7 annually. An average doctor and a private practice have at least 7 regulators that he must be approved before I can practice as a doctor or the facility being made to work. First of all, you must register with Federal Ministry of Health. Your practice must be registered with that. And in each state, we know that we have regulatory bodies. In Lagos, we have a pharma. You must annually register with a pharma. And of course, for those who use ionizing radiation, X-rays, CT, MRI, annually, you have to register with the Nigerian National Regulatory Agency, NNRA. And of course, apart from the normal lawman we all do at our homes, there's a special lawman segment, which is the medical unit. You are not allowed as a practice, as a facility, to throw away your syringes, your plasters, or your gauze. You'll be able to use to treat a patient. That's a special lawman agent, the medical waste management, that you have to register and get a certificate from, and they have to come and take your medical waste to process and dispose for you. And of course, the fire and the safety certificate, you must get that. And of course, we have the data protection regulatory body also, which all facilities in Nigeria now are mandated to register with and be regulated by them. And for those who use some high-level drugs, they also have to register with NAFDA. So we're having a situation in which the facility where a doctor practices have about 7 regulatory bodies annually to make sure that he's doing what he has to do. And of course, as a medical doctor, every year you must register with the Medical and Dental Council and get your certificate that yes, you are good enough to practice for the year. And that means you must have spent at least 30 hours of training the previous year to learn new things about your field, which must show them that you have a certificate that you don't learn new things. So we have a situation in which an average doctor is regulated so much. And so we're to give the best to the patient, where the doctor himself is not catered for. And the good thing which I love is that we have the bill of rights for patients. And if you don't mind, I want us to know that because that is very pertinent for what we're going to do. There are about 10 to 11 of them. The right of the patient, and I do one of the things that even at an hospital, you have to put this at your reception so that the patient will know they are right by the time they walk in. And the first one is that every patient must be treated with respect regardless of gender, race, religion, ethnicity, disability, economic circumstances, or allegations of crime. Every patient has the right to have information in a language and manner the patient understands. Every patient has the right to receive urgent, immediate, and sufficient interventions and care in events of emergency. Every patient has the right to know healthcare team and the right to develop a collaboration plan to prevent recurrence of medical problems. Every patient has the right to decline care, choose or change healthcare provider, and shall take responsibility to what happens if plan treatment is rejected. Every patient has the right to decline or consent to participation in medical research. Every patient has the right to be treated in clean, safe, secure healthcare environment. And of course, every patient has the right to privacy and confidentiality of the medical record. Every patient has the right to timely access to detailed and accurate medical records and available services. And every patient has the right to transparent billing and full disclosure of any cost. These are very paramount to what the patient must get from the doctor. And the other good part of it is that even the doctors also, they have their rights. And the basic right of a doctor to the patient is very simple. There are about 3 of them. That the doctor as a person must be given must give the professional care to patients without any legal or any political interference. That the government and the social services should be a priority for health service allocation in budget. That every doctor has the right to respect and decency. And at the low end, they said every doctor has the right to adequate remuneration for the services he or she must have given. Taking all this into consideration, we know that the patients have their rights, the doctors have their rights. But an average doctor, like I said, has now been in a situation in which it's in an environment that is overly regulated, overly protected, and his well-being, his mental health care, and his social needs are not taken into consideration. So we have a conflict between the expectation of the government, the expectation of the society, and the expectation of the patient, compared with what the doctor needs to perform all these issues. And of course, the doctors have to do what they have to do. And what we need to do, I'm happy about this committee and the panelists we are having today, is that there are a lot of issues, ethical issues, in which a doctor that is expected to give the best to the patient. But infrastructurally wise, there's deficiency. The society has been conditioned that look at health is a social service, not a social business. So an average Nigerian thinks I have to get the health the best at the minimum cost. And I can say globally, health is not cheap anywhere. We need to get the money. How we get the money is another thing, but to give the best in healthcare, we must push in front into that area. So I think what we are having as of now is a situation in which the doctor is expected to do much, but the infrastructure needed are not available or they are deficient. But the society that is expected to help him or her is not there. So it's like tying the hands of the doctor behind them and throwing them into the bath of the society and say, look, fight for yourself. But I'm happy that we are going to get the panelists to handle this today. They are cerebral enough, they're intellectual enough. But like I said, before I finish, I just also have some posters I have to take. And these are live events that have happened to doctors that I have seen. And I'm talking of doctors being kidnapped, and the ransom has been paid. And the doctors is still held and says you should continue treating those who have been kidnapped. And by the time the doctor was released, one of the kidnapped people he treated believed he was part of the kidnapped group. That is a poser, I think, the ethical issue doctors are facing. And of course, the other one is a situation in which a doctor treats an armed robber, non-armed robbery, gunshot wound, and brought him by the armed robbers. And they said, look, we want you to treat this patient. We know where you live. You know where your office is. You get the police involved. You are done for. That's an ethical issue for a doctor. And of course, the commonest one we see that you bring in an emergency to an hospital. The doctor has to treat the patient. The patient gets well and says he doesn't have money to pay. How many times will an hospital be able to afford that to maintain the business? Those are the posters I have. There are a lot of them, but I know there are a lot of ethical issues out there. But as a person who is a doctor, who has seen what has happened, the society expects a lot from medical doctors. The government expects a lot from medical doctors, but the mental being of the doctor is not taken into consideration. The social well-being of the doctor is not taken into consideration. And of course, even the needs of the doctors is not taken into consideration. So I believe the panelists will do a good job to tell us what the way forward in this. Thank you very much.
Thank you so much, Dr. Kuti. I'm already receiving chat say, oh, Dr. Kuti is actually speaking our mind. So thank you for that keynote address. I know it was a very short time to summarize so much, but I really hope the audience has taken some from it. And I think it really sets the stage. To further do this, and before we move on to the panel session, we'd like to put some more context into some of the legal and ethical operational challenges, especially hearing from like a legal professional who has been in this space for a while, in the healthcare space. So we expect to be able to frame these discussions to help anchor this whole session and to give a shared understanding of what is at stake. So we'll call on Mr. Odumbaku. Mr. Odumbaku, to give a brief, set the stage comments on this. Mr. Odumbaku is a partner and sector head of the health and pharmaceutical sector of Jackson and Edu. He's the first vice president of the Health and Pharmaceutical Committee of the Nigerian Bar Association section on business law. He's a member of the medical ethics of a board of a reputable chain of hospitals. He's a certified government relation expert with the Lagos Business School. He's a litigator and legal consultant to a number of health and pharmaceutical institutions on dispute resolution, crisis management, procurement, importation, distribution of pharmaceuticals, medical devices, and the like. He works with the state and federal health ministries on drafting and review of health regulations, policies, and guidelines. Mr. Odumbaku, thank you.
Thank you, Toby, for the introduction. Please, if I could have my slides up. First and foremost, I want to thank Dr. Kuti for that expansive keynote. It has provided a foundation upon which important discussions have to be had in respect of what healthcare institutions face day in, day out. You'll see from the topic, it says defending your practice. In other words, as an healthcare practitioner or as an healthcare institution, there is an onslaught, onslaught from the regulators, onslaught from your patients, onslaught from the society, onslaught, and so you clearly need shock absorbers. You need to be prepared, and hence this webinar. Dr. Kuti has laid a great foundation, and I'm just going to build on top of that to throw more poses on perhaps strategies that we should consider in the course of this webinar. And of course, we are going to take more from the panelists in that regard. Very quickly, go to the next slide. What we see when healthcare institutions are created, it's important perhaps to most importantly consider a compliance framework. Of course, when you establish a business, you establish a practice, right? Just as Dr. Kuti said, before you even start practice, it's crucial to have obtained all your licenses and all that. Ministry of Health, the state regulatory entity, the MDCN, and what have you. However, for that business to continue, for that healthcare institution to continue, right, it's crucial to put in and explore three major issues in the course of managing that institution. Number one, regulatory compliance. Number two, risk management. And number three, crisis management. Of course, compliance has to do with day-to-day, please take it back. It has to do with day-to-day activity of the healthcare institution, whether it's a hospital, diagnostics, laboratory, what have you, right? You have to ensure compliance. That has to do with ensuring that all your practitioners, lab techs, they are all compliant, their licenses are up to date, your indemnity insurances cover are up to date, your standards, right, are also up to date in terms of oxygen, all the things that your practice should have as a practice approved within that specialty, right? You have to ensure compliance. And so we would sometimes recommend that, look, have a compliance audit, right? Regardless of whatever healthcare institution you are running, right? It's crucial to have a compliance audit. So look, well, I've been doing this for the past 10 years, or I want to launch this. What is the checklist I have to meet? And flowing from that, as you continue business, right, you have to look at how the institution carries on business. In other words, what are your SOPs? What are the risk management strategies you have put in place to reduce the chances of omissions, to reduce the chances of negligence, to reduce the chances of mistakes in the course of rendering care? And so that clearly puts in place situations where you have to consider some risk management strategies. Then, of course, regardless of all risk management strategies you may have put in place, sometimes some things will, creep in and crisis comes in. Of course, with crisis, you would sometimes have public relations issues, public relations nightmare. Crisis management, of course, may extend into litigation, may extend into law enforcement situations. And so, what do you also do when you have crisis management situations? These three three-pronged points always have to be considered in running healthcare institutions. And so, moving quickly, right, all we are discussing today is considering strategies tied to all this, right? And also to reinforce that, look, healthcare institutions does not have to do with the building, right? It ties to the practitioners, where you have solo practitioners, where you have hospitals, where you have diagnostic centers, pharmaceuticals, HMOs, etc. Any healthcare institutions within the healthcare value chain has to consider all this. And so because of that, there are common legal challenges within the practice, which of course will extend to licensing issues, medical negligence issues, malpractice issues, employment and data protection violation situations. And so these are common legal challenges that in the course of running whatever healthcare institution you run, or even within your solo practice, because you will see medical doctors sometimes, because of the nature of their practice, they're able to run clinics across different hospitals, right? And so you as a as a solo practitioner itself, it's important to consider compliance, risk management, and crisis management. And so, flowing from that, please next. There are ethical issues, right? As you continue, whichever practice you explore, right? Because it's healthcare, of course, confidentiality is a point that cannot be underemphasized, right? Because the risk to the business is high. Informed consent, where that is crucial, or even getting simple consent is crucial, because without consent, there's exposure. Of course, in recent times, the issue of referrals, right, has become some big issue, especially where you are talking about surgeries, you are talking about transplantation, and also donation of body parts and the like. And so you have situations where things have to be ethically set out so that there is no imputation of unprofessional behavior at any point in time. And so, in considering operational risk, right, the usual vulnerabilities that we that is sometimes seen is, look, inadequate staffing, whereby you see that a doctor perhaps is not well equipped to treat a situation, but he would want to be a hero and takes on such role. I've seen cases where a doctor who is a pediatrician found himself doing orthopedics, and of course, what happened was a situation of a situation of clear medical negligence and body injury that resulted into bodily harm, and so that of course goes to inadequate staffing. And as some of us you will see, particularly for those experienced here, that the first situation, once there is an issue in an hospital and perhaps something goes to the state regulatory entity, the first thing they're going to come up with is, look, do you have the necessary certification to do this kind of practice, So you see that exposure, poor record keeping, supply chain inefficiency, and lack of system, SOPs, right? Without that, then there's huge risk in the practice. Next slide, please. And so, it's crucial to understand the regulatory framework, as I earlier explained, because this ties to compliance. Of course, across the regulatory framework is MDCN, PCN, NAFDAC. Of course, we have a FEMA, depending on the states. We have the Midwifery Council for nurses. And so we have a bundle of regulators across board. Of course, Dr. Kuti had mentioned the patient's bill of rights, right? It's important to state that patients' rights, it extends beyond a single document, right? Because every effort within our laws have been put in place, not just to protect the patient, right, but to ensure that remedies are available. And so as a practitioner, right, within the healthcare sector, you want to be sure that you've covered all your bases within those three scoped points that I mentioned earlier. Please, next slide. And so, one of the strategies we've thought of is that, look, to defend your practice proactively, right, it's important to explore audits are put in place, right? I mentioned earlier about compliance audits. There are also audits that you also want to be put in place to ensure that in terms of the business itself, annual returns, regulatory compliance, you are up to date, right? In terms of the employment contracts with doctors, with consultants, it's crucial to review it to be sure that the institution itself is protected. Yes, insurance is crucial, right? Because once there's any petition, and I'm sure the doctors here know this, once there's any petition at the MDCN stage, right, the first thing MDCN is going to ask you is that, do you have your professional indemnity insurance, right? So whether as a solo practitioner or as an individual or as an healthcare institution, it's important to maintain an up-to-date comprehensive insurance for professional indemnity. And of course, document everything, right? Patient records. Of course, now we have EMR. We now even have cloud-based EMR records where third parties are providing services. Of course, that again comes with issues that healthcare institutions have to be concerned about, where you have third-party entities providing the EMR support for an healthcare institution. Next slide, please, quickly. And so one of the points that it's important to think about is building an ethical governance structure in all, whether as a person or even as an institution, right? Just that, look, this is what we are going to do. ethically, and this is what we will never do as a matter of ethics. Of course, for each profession, there are laid down ethics, right? And so it's important to consider this and have a plan in place in respect of that. Where you have well-established institutions, it is recommended that even if it's going to be a 3-person committee, to have an ethics and compliance committee that would meet. If it's going to be monthly or quarterly, it's recommended. It's important to have also a reporting policy as well as transparency in all the processes of the institution. Next slide, please. And so I'm just going to list some things we've seen in the course of practice, right? In terms of operational best practices, right? Number one, it's crucial to conduct those compliance audits, digitize patient records, of course, continuous training of staff, and also incident reporting systems. Please, next slide. This, of course, keeps your practice in a safe place and also enables you to prepare, right, in the event that there are situations. Because, like I said, your compliance methodology, your risk management strategies would help you sort out crisis situations if and when they occur, right? And of course, a crucial part is data protection, which ties to confidentiality and cyber security. Of course, there's a compliance part to that. There's also a regulatory part to that, which is expected for all healthcare institutions. And finally, next slide, please. And finally, it's important to have a legal support, right? So that as you carry on practice, right, you are not exposed, right? And a part of your risk management strategy is to ensure legal support in the business. Without much ado and without elongating this any further, I would say that of course, we'll share this after the webinar, but it's important to consider the 3-pronged elements that I mentioned earlier: compliance, risk management, and crisis management in defending the practice. Thank you. Toby, over to you.
Thank you. Thank you, Mr. Odubaku, for laying this foundation. Now it is time for our expert panel to really get into the nitty-gritty of the issues. We are joined by distinguished professionals from both the legal and healthcare sector. They will be responding to key questions around liability, risk management, risk mitigation, ethics, operations. These questions are drawn from some of the questions that were posted by the registered attendees when registering. For some of them, we have issues we often deal with, have to deal with. So we'll start with a brief introduction of the panelists. The first would be, well, in no particular order, actually, will be Dr. Onakoya. So Dr. Onakoya is the CEO of Cedarcrest Hospital. He holds an MBBS from the College of Medicine, University of Lagos in 1984. I'm sure a lot of us were probably in the womb at that time. He has a postgraduate orthopedic training at the National Orthopedic Hospital, Igbobi, Lagos, and St. George's Hospital, London. Previously, he was the Group Managing Director of Lagoon Hospitals from 2006, the Chief Medical Director, the Group Clinical Governance Advisor from 2022 to 2024. Under his leadership, Lagoon Hospital became the first hospital in sub-Saharan Africa to achieve JCI quality accreditation. He's a member of the board of Hydra Nigeria Limited.
I think she dropped off, so I'll just take that up. And when you're back, Toby, let us know.
Can you
Are
hear
you back?
me?
Yes.
Yes, I'm back. Thank you. And apologies for the break in transmission. He's an alumnus of the AMP program for Lagos Business School and the Managing Healthcare Delivery and Executive Management program of the Harvard Business School. The next member of the panel will be introducing is Ndili, Ndili, who is the country director of PharmAccess Nigeria. She's currently the president of the Healthcare Federation of Nigeria. She's a founding member, Digital Transformation of Health Lab Geneva, set up to explore new digital and AI, how digital and AI can accelerate UHC in the young population and low-income countries. She has over 25 years experience as a leader in the healthcare industry in both the United States and Nigeria. She's a consultant to several healthcare organizations. She's a trustee of the Nigerian Healthcare Excellence Award. She's also a member of the Health Policy Commission for NESG. Please welcome Dr. Mrs. Ndili. Finally, we have Dr. Daudu. Dr. Daudu is an anatomic and molecular pathologist who holds an MBBS from the College of Medicine, University of Lagos. She has both fellowships, both the Nigeria and West African colleges, specifically in anatomic and molecular pathology and laboratory medicine. She's an alumni of Said Business School, University of Oxford Executive Education in Strategic Leadership. She has certification in leadership and management in healthcare from the University of Washington. She has over 20 years experience in both clinical and administrative roles within the healthcare sector, with training at the Department of Pathology, Indianapolis University, as well as Purdue University, Indiana, USA. She's a member of the Medical Dental Council of Nigeria, International Academy of Pathologists, US, Canada, and West Africa divisions. She has an accreditation from the Advisory Committee of the Nigerian Accreditation System, as well as she's a member of the Business Committee of the Nigerian Economic Summit Group, as well as the Institute of Directors. Of course, she's a WIMBIS mentor and one of the first 50 founding members of the GEA Africa, a first C-suite women-only business club in Africa. Please help me also welcome Dr. Daudu. So now we are going into the question and answer proper. To begin, let's take a look at the big picture. We're talking healthcare providers across the country innovating rapidly, but of course with such innovation comes a lot of complexity. So my first question would be to Dr. Onakoya. In your experience, how as a leader in the healthcare system for many years, what are the top 3 legal and operational vulnerabilities that large multidisciplinary hospitals like yours face today? Dr. Onakoya.
Well, thank you very much, Toby, and thank you very much, JEE, for setting this up. And I think, as Dr. Kuti did say, it is very timely and very topical at the same time. Before, we had always known that the education that doctors have becomes dated after a while. And by the time you've been qualified 8-10 years, most of what you learned in medical school is probably no longer relevant. Or if it is still, there are certainly better ways of doing it. But I think one of the things that we are beginning to see increasingly is a mismatch between medical education and the realities on ground in clinical practice. And I think what I like about the topic of today is defending your practice, because the things that doctors need to defend themselves, their career and their practices against now, unfortunately, they are not prepared for it. They are not taught in medical schools. I'm not even sure if the medical schools themselves have the resources to do that. Take, for example, 2 things. One is social media. Social media is here with us, but how does medicine react to it? How does the doctor react to it? For the institution, suddenly the risk is that 24 hours of the day you are being watched. And the barrier to you, to a patient making a complaint, to you being sued, is now so much lower because it's much easier to gather evidence. Now, whether that is a justifiable lawsuit or not is another matter. The fact is that even if it is a ridiculous one, you still have to mount a defense. You have to spend time with the lawyers. You have to prepare a defense and do all that. And so, but 10, 15 years ago, that was not one of the things a doctor would probably have to worry about. I remember a situation about a couple of years ago in which there was a big row in the hospital. And that is because one of the consultants had found himself being recorded by a patient. And the consultant frowned at it, felt, certainly you cannot record me and record my consultation without my consent. And the attitude of the patient is, yes, but you see, the cell phone is mine and I can do what I like with it. And it was really quite a big debate trying to figure out where to draw the line. And these are the kind of risks that suddenly are in the consulting room of today that were not there before. Another risk, another area that one needs to be wary of is particularly now as credentialing and privileging becomes more and more established in the bigger hospitals. I have seen situations in which people are employed, they are given time to provide originals of their certificates. And when they are told that, yes, now we've seen the originals of your certificates, but we are going to subject them to a credentialing process and do primary source verification.
We still hear Dr. Onakoya. Okay. I think
yes,
you went
I am.
Okay, okay.
Immediately, the candidates know that a process of primary source verification is taking place, they just disappear. And that makes you wonder that that certificate was probably not original in the first place, not real, not genuine. And therein lies risk in which, except you go through this very, very rigorous and time-consuming process, you are not quite sure that the people you are deploying are who they are and they have the skills that they say they do. And unfortunately, at times, it is only when there is a bad outcome that is when you are then going to dig deeper and you discover that you actually employed somebody who doesn't have the skills or the knowledge or the certification that the certificate he or she has presented is. So I think the summary is that what we now see in the consulting room and medical practice of today, I'm not sure that the practitioners that are coming into practice are prepared for it, are trained for it, and are ready for it. Thank you.
Wow. Thank you, Dr. Onakoya. I think all the points you have made are extremely important in this context. But I understand that not just for hospitals, of course, diagnostics lab also have some other, issues, right, with growing reliance on precision and data or data and automation. So maybe I think it's a good point to just flow into the next question, which is addressed to Dr. Abiodun, on operational and legal risk in diagnostics. So from Cedarcrest's perspective, what are the most pressing legal and operational risks you encounter as a diagnostics powerhouse? Dr. Abiodun.
Thank you very much, Toby, for the question. I don't know if you can hear me.
I can hear you.
Okay, great.
I can see you now.
For that question, the vulnerabilities that a diagnostic center faces are around, well, majorly, I would say, first of all, information technology, because for an organization like ours that's hinged, our processes are hinged and the entire value chain of the services we render is on IT. There's a very big risk to IT infrastructure, and this can be primary. It could come from breaches in the system, so cyber crimes against the organization primarily, or exposure to cyber security challenges from our partners and the vendors that we practice with. Another vulnerability that diagnostic centers face, because we work with a lot of reagents, we work with a lot of equipment that are not produced locally and usually ferried from other places. You can have supply chain challenges that can affect the operations of the business that you're running as well. And in speaking about the IT challenges, I think a big one now with the NDPR is breaches in patient data that can lead to also, legal action against the organization that can be very costly. Those are the ones that come top of mind: IT infrastructure, and then, supply chain issues, as well as breaches to on clients' biodata and information that is gathered during the course of service delivery.
Okay, thank you. Thank you so much, Dr. Daud, for explaining this. I would just want to quickly ask that anyone who has questions, some people are already putting in questions, should please use the Q&A chat. Any question you have, I will be very happy to respond to them, after we are through with some of the questions we already have. Moving on, we also understand that some of the pressures on an institution is not just from the operational, they're also institutional pressures. So let's zoom in a bit. From a legal advisory point of view, how can providers really navigate this terrain? So Ms. Alubak will be calling on you to talk to some of the common legal pitfalls in the healthcare practice. What are some of the most common missteps that you've observed across the healthcare providers in Nigeria, and what practical steps could they take to avoid these traps?
Thank you, Toby. So, I think a good number has already been mentioned, right? Number one is data protection, right? Putting in place measures for data audit and also for confidentiality. Sometimes you walk into a hospital, you see the front desk person, perhaps with no training, saying, Mr. Odumbaku, what's your phone number? What's your address? Let me help you fill the form, those are confidentiality issues. You also see a good number of healthcare institutions. There's rarely no plan to comply with data protection, with the Nigeria Data Protection Act. In other words, putting in place audits and all that. Then also in terms of operational missteps, right? One that we often see is in terms of informed consent, right? Sometimes some practitioners are often in a hurry to do procedures. In other words, the Code of Medical Ethics would ordinarily expect that, look, you give a good time in between a major surgery or a major procedure from the time the patient is advised of the risk, the benefits, to the time the actual procedure is done. So, but you see sometimes practitioners are in a hurry to do a surgery without allowing the patient review, consider well the options and the steps and the risk, right? For instance, if there's a 30% chance of something wrong happening, what are the details of those issues coming up, right? Because eventually that 70% that you think may be the best chance scenario, might not come up, right? It might now be the 0.01% chance of failure that comes up. And if you didn't advise the client that, look, there's a 0.001 chance of this happening in the course of the surgery or in the course of, then the patient is going to say, look, I didn't give you informed consent. And so you perhaps didn't give me full information on the nature of the treatment you were rendering. We see that a lot. Then I think one particular one is a good number sometimes does not have SOPs, no standard operating procedure to enable a new practitioner that joins them, to say, look, this is how we do things here, in compliance with ethical obligations, in compliance with the professional standards, even if, just as Dr. Onakoya mentioned, even if you had gone through the whole training, right, after a particular time, right, it's important to have some retraining. And so there's need to have SOPs internally that will be upgraded so that the standards get up to date. And so these are some of the issues I reckon would often come up. Thank you.
Thank you, Mr. Odumaku. We understand that risk isn't always internal. It sometimes flow through contracts we sign and third parties we work with. So I will just move on to quickly ask Dr. Onakoya, in terms of third-party liabilities and strategic contracting, how can hospitals structure their relationships with people like HMOs, labs, equipment suppliers to insulate them from liabilities due to external errors or misconduct? Dr. Onakoya, if you could just address this question.
Well, thanks again. And I think this is a particularly important area because it is so easy to be vulnerable and not to know it. And most hospitals will assess their strengths and assess their offerings based on their clinical offerings. How many surgeons do we have? What procedures do we do? How capable is our ICU? And neglect often two very, very important areas. Before, it used to be finance and accounts and legal. I think more and more as hospitals realize that, medical practice is a business, the financial aspect of things is being better addressed now, but not so much the legal. The number of big hospitals that I know that have either an in-house legal department or have access to legal advice, I probably could count on my hands. A lot of times, the legal aspect of their work is very reactionary, is when there is a trouble, is when something has gone wrong. But I think this is better prevented right from the contracting stage. And so my number one advice is that this is an area that you know next to nothing about. Even at times, the English is a bit, I don't know what adjective to use now, but Toyosi and Okorocha know what I'm talking about. So it is an area that is alien to doctors, and you do need to get competent advice. And my suggestion is that you do that as part of your setup, so that even from the contracting stage, you are able to, as much as possible, cover all the bases. With regards to equipment manufacturers, where does the liability lie? If you use the equipment as you should use and it produces a false positive and you do an operation you should not have done, then where does the liability lie? If the equipment is supposed to function for so many hours before it needs to be serviced or maintained, but somehow develops a fault before that, there are so many of these areas that it is only when you have access to legal advice at the contracting stage that you are then able to protect yourself. Also is with regard to people who provide third-party service to you. Now, it is not unusual to have very, very senior, very, very highly skilled professionals, but who for some reason or the other don't have indemnity insurance. It means that if they practice in your facility and something goes wrong, then you are liable. And if you don't have access to the right legal advice, then you will be exposed without knowing it. You probably think you have a rainmaker surgeon working for you or a rainmaker physician, but really there is considerable risk that comes to that. So I think right from the beginning, you should get proper legal advice. And the HMOs already do. So if you are working with HMOs and you don't have legal advice ab initio, then already the scale is tilted against you, particularly when it comes to the fine prints of language, of credit control, of receivables, of payments being denied and all that. So I think this is better prevented. It's a minefield for hospitals, and you do need people who are familiar with that terrain to help you navigate it. I don't think it will be seen as a cost. It will be seen as one of the necessities for proper medical practice. That is, you either having a legal department in-house or ready access to one, not just for reactionary cases, but for ongoing advice. Will be my take on that, Toby.
Thank you, Dr. Onakoya, for
my 3 minutes
I believe
done,
hitting
so
the nail on the head. Okay, so speaking of structures, it is often argued that public facilities lag behind in terms of some of the quality benchmark. I think at this point it's important to just take it to sort of like the higher level in terms of not just the private facilities, but also the public facilities. How does stricter legislation for private care inadvertently widen inequality gap? So we'll be asking Njide and Ndili about quality and accountability in both public and private healthcare. What are some approaches to enforcing accountability across public healthcare institutions without deepening systemic inequalities?
Well, thank you very much. A lot has been said, and I think at the root of all this is systems and structures. First of all, it's important to understand what health accountability is, quality accountability in health. And the responsibility lies on both the patient and the organization that is providing the quality. And you talked about public and private. First of all, there should be a distinction, not in the quality of care that should be provided, but the structure that governs the two. First of all, in private sector, the owners or the managers come with a sense of business. Let's put it that way. They do things well. They set up properly. And try to hire the right people. They have a sense of responsibility, a sense of what they're trying to achieve in terms of patient outcomes and how they set up. I wouldn't necessarily say that their goal, their main focus is profit, but ultimately, I think that they look for sustainability. First of all, ensuring that there's good patient outcome, which of course will always lead to the bottom line. If you look at the public sector, it's a whole different ballgame. It's not that they don't want to provide good quality care, but the structure that puts the personnel in place and the structures that govern them are somewhat different. You can say that in the public sector, how would I put it? They have a sense of, first of all, they're doing the patient a favor. Or, have you ever tried firing a doctor in the public sector? It's almost impossible. A civil servant is, so they come with a sense of, this is my job. And, there's little or very variable accountability structures in place. So having said that, I think it's important to, first of all, putting some regulations, structures that could govern both public and private, so that there's the ability to benchmark. So for example, in Lagos, we have HEFEMA. I think HEFEMA was mentioned before. HEFEMA regulates and licenses healthcare organizations, both public and private in Lagos. You have NEFRA, which is now the Nigerian Health Facilities Regulatory Agency at the federal level, which it's been I think Jackson Etti Edu is in the process also supporting the bill that will establish that facility, that agency to oversee and own the standards that will be put in place. But aside from that, we as PharmAccess and also the Healthcare Federation have been advocating for some kind of quality methodology. So for example, there's Safe Care, there is SQHN, which kind of tries to establish the baseline across processes, infrastructure, equipment, and the human resources for health. One without the other will give you a variable outcome. So it's important that these are put in place, and also a way to incentivize quality improvement towards healthcare delivery. Without it, the accountability structures are very, very different. And it's difficult to hold anybody accountable for the quality of health outcomes that the patient receives. Over.
Thank you. Thank you, Ndili. Njide, Ndili. Thank you. Let's just talk a bit more about the next question we have, which is centered around navigating ethical tensions with patients. Let's explore a bit more the nuanced challenges, navigating ethical dilemmas in real time, especially when multiple medical voices are involved in patient care. I'm sure we've seen this as both doctors. We've seen these instances when quite often you are trying to treat a patient and they tell you, oh, I have one cousin who is a surgeon somewhere in the world, in the US, and this person is telling us that we should go down this path. We see it so often. How do you manage situations when patients insist on advice from an external doctor who contradicts the in-house team? Where do you draw the line to protect your institution where there is any fallout? Dr. Onakoya.
Well, I must say that's a fact of life for me. It's a very, very common occurrence. And once again, we go back to that word that Njide did mention, and that is having a structure. And it's always good to have a structure in place, to have an SOP, to have a process in place before this happens. So that, because inevitably it is going to, and when it does, all you are then doing is just following your process. And it doesn't then matter whether it's a junior doctor that is on duty or it's the consultant. There is a process to follow. That is the first thing. What I suggest to doctors is that as part of your practice, first of all, the patient needs to give his or her consent. That is the first thing. The second thing is that as part of your own SOP, have a credentialing and privileging process in place. Credentialing means that anybody that will touch patient either by surgical means or providing advice or treatment, we know what your academic background is, we know what your qualification is, and we have verified that qualification. And we have then confirmed that that qualification suffices for you to practice with us. That is one. Privileging recognizes the fact that you treating a patient in a facility is a privilege, and it's a privilege that can be given. It's a privilege that can be withdrawn. So when such a request then comes, what I usually will do is, well, first of all, we need to know who this person is. The fact that he is your cousin or he is this or that, calling from St. Elsewhere's in the US, for example, does not mean that that person is competent to practice with us. And it doesn't necessarily mean that his or her opinion is superior to what we have. But we have nothing to hide. So we will take that person through that process, through a privileging process, through a credentialing process. Once that is done, best case is to then invite that person to join an MDT. Usually the cases that they tend to get involved in, or families will ask some external opinion to get involved in, tends to be the ones that are not so straightforward in terms of outcomes or in terms of treatment options and what have you. And this person wants to weigh in on one treatment option versus the other. And usually in an ideal world, such a case should be reviewed by an MDT. An MDT is a multidisciplinary team of people who will be involved in the care. It might be a surgeon, it involves an oncologist, a physician, a nutritionist, everybody that will have a hand in managing that case. And what you can then do is offer that individual to be part of your MDT. and it will then be his or her own opinion in a pot where we are reviewing all the possible opinions and trying to come out with the best option. I think the worst thing you could probably do is to say, no, we know what we are doing. Are you questioning us? For me, that is a no-no. It suggests that you are not on top of your game. It suggests that you have something to hide. It suggests that you are not comfortable with scrutiny. I think you should be happy to welcome that advice, but let it be known that it is not, that opinion, sorry, it is not in any way superior to the local opinions. There is a process here. So far, your cousin or your friend or your family member is happy to blend and be part of that process. Oh, certainly, we are happy to listen to him. That would be my own suggestion. But I can tell you, if you already have not experienced that, just watch this space. It's going to happen. Thank you.
Thank you, Dr. Onakoya. We'll have, I'm sure we definitely have learned, because I understand that a lot of medical practitioners sometimes feel threatened when it seems as if opinions is coming from third parties. So it's important to note that those people can be brought in and thought about as part of the team. We'll just move on a bit to hear a bit more from the diagnostics point of view. How does, and we'll address this question, of course, to Dr. Daudu. How does CyberLancet embed confidentiality, accuracy, and consent into his everyday workflow and reporting structures?
Thank you, Toby, for the question.
Here it is.
Thank you very much. So the way we imbibe patient confidentiality, data accuracy, and informed consent into our operations through protocols and processes that have been put in place from when our patients walk in and how they make requisition for their tests at the reception, basically, which is done by the patient. We also have a flow where you have two personnel that has one person receiving the information and inputting it into the system. So we have what we call loggers and receivers. And this is just the logger will collect the initial information to impute into the system, while the receiver kind of quality assures it. So it goes over it again to ensure the information that has been entered by the logger is correct. Those are ways that we use to ensure that we have correct data in the system for the patients that come in. For the informed consent, certainly we read through the procedure of what is to be done, whether it's from the point of collection of the sample, verifying what tests these patients have coming forth that have been given to them by their physicians before we enter them into the system and log them. And in terms of data protection, we ensure that we have a foolproof cloud system that protects the data that is entered into our laboratory information system. So basically, those are the ways that we ensure that we follow through with our ethical obligations in the data that we receive from our patients.
Thank you, Dr. Daudu. We'll just talk a bit more about some of the ethical strains, which sometimes come from limitation of resources, especially in places like the rural areas. We'll now move on to Ndili. Mrs. Ndili, next question, please. Where we are talking about ethical challenges in overstretched facilities. I know probably CyberLancet wouldn't have that issue, but for sometimes the rural areas or places maybe outside cities where we see, of course, you know, for migration of healthcare, I always say that, or I've heard it said that migration of healthcare, when some people are moving abroad, the people from the capital cities, sometimes the people from the rural cities or places that are not the capital cities are then moving to places like Lagos and Abuja and Port Harcourt. And from there, it's sort of like a pipeline out of the country. How do we do we ethically balance patients' rights with operational limitations in overstretched facilities and personnel, especially in rural and peri-urban centers? Ndili, please.
That's a very tough one because I think the issues are very different. As you know, a patient-doctor ratio in Nigeria is extremely bad. You know, WHO recommends 1 doctor to 600 patients. I think in Nigeria now it's 1 doctor to 9,000 patients because we have most of our doctors still leaving. But that's even worse in some of the rural areas where you can have as much as 1 doctor to maybe 45,000 people. We're dealing with that, or we're seeing some of that in some of the programs that we run. So I think that it's important to, first of all, try to balance or even spread out or incentivize providers to extend their practices to underserved areas, but with the same notion of patient rights and responsibilities. You know, we've passed this National Health Act, which makes health insurance mandatory, but yet we have less than 10% of the population covered. We have more doctors in Lagos than you have doctors all over Nigeria. So there are definitely kind of regional disparities and imbalances. So I think that the first thing that we need to do really as a nation is to find a way to implement, so first of all, in the urban areas, triaging protocols, because we're also seeing that there are more patients in tertiary institutions than you have in primary healthcare centers or private GP practices for those that exist. So how do we, you know, ensure that patients, first of all, have access? So that's a whole different discussion, which I don't even want to bring into this. How do they understand what their rights are? Those in the urban area have, you know, understand their rights better. When you're paying out of pocket, you understand your rights better. So there are quite a number of discrepancies which we have to try to balance. And the best way to do this is by enforcement of this National Health Act, which makes health insurance mandatory. At the same time, you have to also shore up the supply side with, you know, tools such as triaging protocols, task shifting, the use of technology like telemedicine, decentralizing services, you know, ensuring that there's the workforce capacity building. There's so many different interventions that could happen. I'll give you one quick example of what I'm actually explaining, which is a program that we run in Delta State. I keep mentioning this because it's so critical and is an example of how we can balance patient rights with you know, good quality care. A community almost 3 hours by speedboat into the Niger Delta Creeks, where the facility has been built by Chevron and donated, fully equipped. But yet there are no medical doctors in place. And we engage the private sector to reach out to run those facilities and then, you know, be able to provide services. What we saw was actually monumental and very encouraging in terms of what could potentially happen, especially for those who don't even understand what their rights are and who want to access good quality service. Using the method that oil companies use, where they're moving doctors in and out on a shift basis, 2 weeks in, 2 weeks out, we saw a transformation where patients were now willing to come in because they had insurance through the Basic Healthcare Provision Fund. Even those that wanted to pay out of pocket were able to pay. So it's important that providers who are providing the healthcare services understand that the patients are their clients, if you put it that way. And the patients understanding that they too have a responsibility to either pay or find a way to be covered by some kind of insurance, but understanding where the different expertise lies and how to make sure that that comes together. So the important thing to note is that there has to be a way that providers can extend their healthcare facilities, or almost running is kind of like a franchise where you can extend in a hub and spoke model to different areas
Yeah.
of the community and be able to extend that best practice, just like practices like Dr. Onakoya, whether you've actually considered having outposts in regional and rural areas where you can, just deploy simple consultations as a GP practice and be able to then refer to a central location. That way, you're extending best practice, not just in a central location, but to decentralize it where the patient can actually access that care, and that way transfer capacity towards less, areas with less capacity to provide care. I think I'll stop there for now. I think the time that we're given is so short that you can't really on what you're trying to
Yes.
explain. I hope I was clear.
Yes, you were very, very clear. I'm sure you have so much more you could have mentioned. But one key thing you talked about was cost and insurance. And obviously insurance is such a big deal. But before we get to the point of universal health coverage, insurance coverage, we are still at this point where most people are paying out of pocket. So that's why the next question, we'll talk a bit more about cost. I see is interestingly, someone else had put a question similar in the question and answer to this question, which is a question of cost recovery in cases of non-payment. And if we could to just address it to Dr. Onakoya, in your experience, what are the legal ways to recover costs of medical care when patients refuse to pay their bills? For instance, when they claim to have run out of funds, or when complications lead to higher than expected charges, or for other reasons. Yes. So of course, I'm sure every health institution, in fact, I've heard, I think some 5-10 years ago, I heard one of the larger hospitals in Lagos had a debt profile running to hundreds of millions. People were coming to access care, and some of these were very rich, reputable people, but they just were simply refusing to pay. So what are the legal options available to to a healthcare provider when patients just refuse to pay? Dr. Onakoya.
Well, I think this is the dreaded nightmare in hospital administration,
Yeah.
really. And I think by the time you are exploring legal options, then you have missed the boat. Ideally, you should, as much as possible, avoid being in this situation. Before, we used to think that once you get the patient to sign an indemnity to pay before the surgery is done or before they are admitted, then that suffices. But more and more, what we are seeing is that even when an indemnity is signed, it is difficult to enforce. So I would say the first thing is, please, as much as possible, avoid being in that situation. And try to avoid fee shock. Try to avoid a situation where by the time your system is aware, the patient is owing several millions of naira. You see, if the patient is owing a few hundreds of thousands, then the odds are still in your favor. You can discharge the patient or refer the patient and say, look, you can go with it, we don't mind. But if the patient is already owing you 18 million naira, then if I were the patient, I know that I hold all the aces. If you keep me, then I will go and complain that you have been kidnapped and you can't keep, everything is just against the hospital. So I would think, first and foremost, try and avoid that situation. The second thing is that there are some steps that they are a slippery slope to this situation. One of them is, before you are sure that a patient can fund the care, in the rush, the patient is intubated and is ventilated. Now, once you are in that situation, there are no good options anymore, because every other thing that you do, you can't disconnect the ventilator. You'll be accused of manslaughter. You can't simply say you are going to refer the patient, because good ethical practice demands that you must refer the patient to where they can get appropriate care. So I will say the first thing is avoid that situation. More and more now, there are firms that provide services that wasn't available before. So even before you get to the legal option, you can have an agreement with a credit control firm. Some of them, if they are a debt owed by reputable people, they are happy to buy the debt or to pay some amount upfront ahead of their recovery. So I think there are a few other options that are available to you before the legal one. Once you the only options you have are legal, I'm afraid you've missed the boat. But again, there are legal firms that are very vast in medical law and health jurisprudence, and they are then able to help with regards to what options do you have. But really, in summary, what I will be saying is that, yes, retain a firm, a legal firm, so that they can advise you. And in the process of recovering that which is duly owed to you, you don't break the law. I think that is even more important than the amount that,
Yes.
well, just as important as the amount that is owed, that you then break the law in the process. But also, I think, to try as much as possible not to be caught. Once you are in that situation, there are no good options, I'm afraid. Thank you.
Thank you. Thank you, Dr. Onakoya. What you have said has dwelt a bit more on some of the risks that we'll be exploring. No good option when, of course, they are on social media saying that, oh, you have kidnapped or you have constrained them from leaving your hospital. So we'll just speak on some of the reputational risks and threat, and of course, the risk in the diagnostics area. Sometimes, despite best efforts, some things can go wrong, right? Especially in diagnosis where there is a razor-thin margin. How does the organization, Dr. Edu, mitigate risks from things like false positives, delayed results, mislabeling? Is there an internal audit mechanism or protocol that can help, Dr. Edu?
Yes, thank you very much, Toby, for the question. So, as you know, Lancet Nigeria is an ISO 1518 accredited laboratory, and that's the highest level of accreditation for medical diagnostic laboratories. And what it does is, what it speaks to is that you're practicing with the best international practices that have been audited by an accreditation body. And risk mitigation is one of the big parts of this accreditation, especially the ISO 1518-2022. So in mitigating against issuing results of false positives and false negatives, and also reducing delay in reporting, some of the things that we implement in the organization is to ensure that we validate the reagents that we use and even the machines that we use as well in carrying out this test. And it's very important for us because a lot of people that are not well versed in quality management system just sometimes maybe buy machines and start running tests. What we do is that before we use any reagents to carry out any tests, we validate it. And validation has to do with collecting samples. We have some known samples and testing across the spectrum of whatever the analyte is, high level, low level, identification of whatever you're looking for in the testing. So we do that, and we ensure that we try to get good quality kits in running the tests that we carry out. We also use controls in validating these kits, which helps us when we're talking about avoiding false positive tests. And we try to deploy more high specificity tests for whatever analytes that you're looking for. Now, for the false negative test, to avoid that, you're going to look at using high quality test sensitive kits to carry out those tests, and to also use different methodologies in looking out for those analytes. The process that we have in place to mitigate against delay in reporting is that we pull incompletes within the frequency of 3 to 4 times every day to ensure that we are being proactive in terms of following through to see which results haven't gone out and to mitigate against that. Sometimes you can have delay in reports because of failure of IT, because a lot of our results go out through emails and co, and sometimes it's completed on our end but doesn't actually file through to some of the emails. So these are some of the things we've seen that contributes to delay in reporting. And then we also have a protocol in place for critical tests. So high potassium, or what we call critical testing, are usually called out. You don't even wait for it to be issued from the system. A phone call is placed across to the physician or the organization that needs that result to look after the patients. These are some of the things that we try to put in place following the strict protocols of the ISO system that we have in place at the organization.
Oh, thank you. Thank you, Dr. Aldo. It's very important.
Last but not the least, to avoid that, we take part in training of our staff, capacity building, and we also have external quality assurance system, monthly proficiency testing for all of the analytes that we carry out in the lab. From January to December, all of the personnel in the lab running the test have an external quality assurance sample that is sent to all of our laboratories for them to test against an international pool. And we use those to implement mitigation plans in terms of if we have to retrain and, you know, how they are performing on all those tests that are carried out within the lab. So those are some of the ways that we try to mitigate against these issues.
Thank you, Dr. Aldo. We've heard, you know, very important training and quality control, quality of everything up and down the value chain. But we do know that whether not just from laboratory, also from hospitals and every healthcare provider, no matter how well you do, there will always be quote unquote mistakes, right? Yeah. So I would throw this to maybe Mr. Odumbaku. Are there ways that preemptively your institutions can shield themselves from medical negligence claim? Or sometimes it may just even be people who go on social media to claim, oh, this hospital has done this, or this laboratory came and did this, when sometimes it's not even true, right? Or they tell you, oh, I'll go on social media, you know, if you don't do this or do that, or, you know, or say it in any way they want. So how do institutions protect themselves from such negligence claim or such media onslaught? Odumbaku.
Yeah,
Mr.
thanks.
Odumbaku.
Yeah. Can you hear me?
Yes, we can.
Okay, so look, PR, the bigger your business or the bigger the hospital or the diagnostics entity, the higher the likelihood that a patient would want to throw a PR threat in the face of the institution. Of course, PR claims, social media claims are not to be ignored, right? And so it's important to consider, number one, the details of whatever is the event that may have occurred, and two, how to react, right? Sometimes it's not in all cases you want to do a reaction. Again, because whatever may have happened between the institution and the patient, right? The healthcare institution, unfortunately, has a duty of confidentiality. It cannot waive, right? Of course, the hospital, and again, that's why it's always a difficult situation. The patient, right, is aggrieved, has gone to social media, but the hospital cannot just rush to social media to say that, we did our part, we took care of you, these are the details of the care, because by doing that, you have exposed the practitioners and the hospital to more risk, legal risk, because of the duty of confidentiality and all that, and data protection. And so perhaps a way to avoid all that is, as much as possible, manage patient complaints immediately they arise, right? They are expected to be escalated, not just at the manager level, not just at the attending doctors level, but also at the medical directors level, because of the huge exposure that can cause to the healthcare institution. That's one. Two also is that, look, it's not all social media claims that you perhaps have to respond to as a healthcare institution. Yes, perhaps every now and then it might be important to put out a statement to say that as a responsible entity, organization, we have high ethical standards, we have high quality standards, and we would take care of our patients, in the best possible way. Yes, it might be appropriate to put out some general statement, but I must say that it's not all the time, as a matter of strategy, right? Because again, by putting out statements, depending on some scenarios, you would only provoke, you would add fuel to an already
Blazing
serious
fire.
situation. For instance, a patient passes away in a hospital. The family is claiming
Yeah.
medical negligence. Perhaps they didn't understand what transpired in the course of the care, and one of the family members rushes to do Instagram Live, and everybody is commenting. And of course, if the hospital says something, it may
Okay.
also be expanded, to other limits. So sometimes it's important to review, right, strategize, and de-escalate as much as possible. In fact, the strategy should be to de-escalate. If the statement you are going to be putting out would rather cause an escalation, right, in a PR situation or in a social media situation, then you are doing more damage than to resolve the situation. I don't know if that answers your question.
Yes, I think it does. And to save time, we'll just take one more question, then just go to the question already in the chat box. I can see time is fast spent. I thank every single attendee who has continued to stay on this call, as well as our speakers who have taken time out of their valuable time out to come here to speak to us and to give this information. Just one more question, which is to Ms. Ndili, on liability in digital healthcare and algorithm decision making. The intent now is AI. People want to have AI diagnose them with all sorts of things. I always say that one thing with Google is that no matter what symptom you have, it turns out to be cancer for some reason. Just Google anything on or any symptom, cancer must be there. But I would ask to as the country director of PharmAccess, we know PharmAccess supports health financing and quality improvement and the promotion of digital healthcare solutions, which you already also alluded to. How do you address health providers' concern with liability when algorithm-driven recommendations result in negative outcomes?
First of all, I would say get a liability protection. That should take place. In the rest of the developed world, every doctor has, liability insurance. It's very important, but not to minimize your question. I think that we begin to see digital as the end-all be-all. I must emphasize it's an enabler. It cannot replace clinical judgment. That's the first thing. Second thing is that the current AI systems that we currently have are using data from white men in Europe and so on and so forth, that we don't have enough, we haven't accumulated enough data from our own environment that can feed these AI systems, which is something that we need to do. So it's important that even though we're still way back, that we already begin to develop policies that can define, the accountability of data use and how this data is, communicated. So the first thing we need to do is strengthen our governance. Luckily now we have NITDA, but we're still way behind. We need to ensure that the right systems are put in place. After all, when you talk about digital, we talk about enablers of digital health, power, electricity, in hospitals, data, literacy, and so on and so forth. A lot of these are non-existent. So I think it's important that we, first of all, as a country, and as a government, because a lot of it is infrastructure, which is the responsibility of government to put some of these things in place. Then the governance needs to hang over. Do we have the technical capacity to be able to develop the governance structure? Are we copying and pasting from other countries? These are some of the things that even I am currently working on to see how we can support the development of some of these. So we're still at early stages yet. So the best advice I can give is get liability insurance. Our population and enrollees are getting more and more aware. So they are going to resort to legal recourse. So for doctors, it's important really that they use digital technology right now as an enabler. Don't discard your clinical judgment, because ultimately that will be what you would rely on until we have confidence in the data that is feeding the AI systems. So I'll leave it at that.
Thank you. Very, 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 very important. Thank you, Ndili. Now we'll take the questions from the audience. There were a few other questions that were pinned down, but I think, due to time, it's just important to zero in on some of the questions our audience have. So the first one from anonymous attendees, we also need more diagnostics discussion. I'm sure we've been able to improve on that. The regulatory compliance in the diagnostic sector is more stringent than that of pharma. We would like the panel to discuss and dive into this. I'm certain that Dr. Abiodun has a lot more to say on this topic. Maybe this is one of the discussions we think of having subsequently, maybe something subsequently focused just on diagnosis, because as this person has said, it's a very important. Come back on this. Then Dr. Babajide Famodu has asked, as the use of AI increases in every aspect of healthcare, what ethical dilemmas do healthcare providers face in the moment? Doctor, I don't know if any of our panel members wants to drop on this. I know some comments have been made on this recently, but please feel free to jump in. What ethical dilemmas do Nigerian healthcare systems face at the moment?
No, I was going to just answer the question by suggesting that doctors and health facilities need to build their own capacity. They need to move with the times. I think that it will get to a stage where the doctors who are engaged within the healthcare sector, one of the primary skill set is the ability to use digital technology. So with that comes the ethical considerations and how that technology is applied. So it's very important. If I just also give the example of the wide variety of CPT codes and diagnosis codes and what have you, there's no way that a doctor can have all that stored in their head. So it's important that we use AI or digital technology to assist the doctor. So it's an enabler. It will help you make better clinical decisions. And this is where I think that doctors need to step up and use that as what I will call a back to shore up their diagnosis and their clinical provision that they give to the patient. Over.
Thank you so much. We'll move on to the next question. This is a rather broad comment. How do we partner to move the healthcare forward by working as a team? From Omotola Leke. Regardless of the situation of things or the economy. I'm sure this is a broader conversation that we can continue to have. But if anybody wants to, any of our panel members wants to jump in at this point.
I can say a few things about that. But before saying that, I was just going to say a couple of things in addition to what Toyosi was discussing a few minutes ago. And that is that I think all doctors should have it as part and parcel of their practice. 2 words: communicate, document. Communicate what you document, document what you communicate. And if you do those, then you will build trust in the patient even before the bad outcome comes, even before there is the bad outcome. And then they are more willing to have a discussion. You might not still necessarily convince them, but at least they are more willing to listen to you to understand what could have gone wrong. Also is, I think all doctors know about the duty of care. I would suggest that a higher level of that is a duty of candor. And you should approach looking after your patients with a duty of candor in mind. Having said that, I think, yes, everybody likes to be MD, everybody likes to be CMD of their own hospital. I mean, and I think the adage goes that the Englishman likes to be the ruler in his or her own empire. So fine, in his or her own castle. But having said that, I think the more we look at our practices as business entities, the more we acquire the skills, and Njide was talking about IT skills just now, the more those who are in healthcare leadership also acquire some numerate skills. They can understand when their accountant is talking about P&L. They can understand when he's talking about their balance sheet. The more they will see that even though cash is passing through, but this business is not thriving and this business is not sustainable. In my own street on Moriokwala, at the last count, there are 11 healthcare facilities on that street. And yes, some of them are single specialty things, but about half a dozen of them are full-fledged hospitals. I don't know what their utilization rates are, but all across town, certainly I think we should become more and more comfortable with collaborations, even if we don't go through the full hog of mergers and acquisitions. But I think there is no point every facility striving to have their own CT scan, their own cath lab, their own MRI, when by collaborations and coming together, we can pool efforts. There is currently an effort now with some of the bigger hospitals on the island, just looking at supply chain. How can we eliminate the middleman? How can we strengthen the supply chain? What strengths do you have that are my own weaknesses? And these are things that are very, very, given with regards to private businesses. And I think as healthcare facilities, we should also look at that. I think collaboration helps us to acquire volumes that single-handedly we don't have. We have a bigger leverage when it comes to supply chain. And it is something that we should be looking at. JEE, I think, we can even cite that example. JEE is 3 law firms, if not 4, that have come together. Maybe that is the model which you should be looking at in healthcare. I join Njide in saying over.
Thank you, Onakoya, Dr. Onakoya. We'll just quickly ask the question from Festus Adetun. Also, what are the shortcomings associated with phone consultations and prescription? Telemedicine everywhere. What are the shortcomings associated with this?
Yeah, perhaps I can jump quickly on that. In terms of shortcomings, right? Number one, there's the risk of not properly documenting, right? And so again, it can fall into a debate what the practitioner said on the phone or did not say. Two also is that there is also a risk of being recorded without consent, right? Such that interpretation of whatever was said can then be taken against the practitioner or against the patient, depending on which the situation. But it's the exposure to it is just high. So of course the recommended practice will be, look, it's either you have a proper telemedicine consultation, whereby things will be recorded, properly filed in the EMR records, or you ask for a physical consultation. Then also, particularly the risk is that, look, depending on the patient, you don't want to offer telephone consultation when you should be physically observing the patient, right? The risk to in negligence, is high in that regard, particularly professional negligence.
Thank you. Thank you. It's those are very important points. Let me just quickly look at the next option. Okay, we've already addressed this. What legal options available to hospital when patients are willing to pay bills? When a surgery goes wrong and a patient develops extra complication, who pays the extra hospital costs? I think we've tangentially addressed this as well, right? Is it ethical to reject critical patients or accident claims due to lack of advance payments for treatment? I can quickly answer this. I know the National Health Act mandates emergency care should be given, at least stabilizing care. So it's now a matter of law that must be done. So no, you cannot reject emergency care. How is the need for payment balance in the case of emergency? Police case in case of emergency also comes to mind. I think that this flows from that. Can you hold on to a patient's corpse if the family refuses to pay their hospital bills? Does anyone want to? I think this is probably the SOP in some public hospitals, but it'd be great to get perspective on this as well.
What was the question again?
Can the healthcare provider hold on to a patient's corpse if the family refuses to pay their hospital bills?
No, that's disallowed, right? Especially where the death certificate has issued and the relevant documentation for burial has issued. Of course, debt collection methods can be explored, right? Where the patient passes and there are bills to pay. Like Dr. Onakoya said earlier, right? It's not, I don't think that's disallowed. And again, can be exposure to the healthcare institution if that happens. Just
Okay.
employing
Thank you.
lawyers.
There's a question specifically addressed to you, Mr. Bakun. In cases where the patient has already revealed his personal details and health records on social media, can the hospital go to the same media to set the records straight? A patient has also revealed or a patient relative sometimes has already revealed personal.
Hello, Toby. Can you hear me? Okay, to answer the question, right? Even if the patient has revealed his own personal information on social media, right? Again, it depends on the circumstance, but as a matter of practice, right, and as a matter of policy, I don't think any healthcare institution or practitioner will be encouraged to go on social media and be doing back and forth with a patient on social media. It's highly, in my opinion, it's highly unprofessional, and there is going to be a risk of you disclosing confidential matters. And so that patient, even though he or she may have gone to social media to disclose her own personal matters, can then pick and choose and say that, no, you shouldn't have disclosed that one. It wasn't a matter of public record, you know. So the risk is high. Recommendation would be avoid it if possible, whilst you explore other public relations mitigation strategies, you know, as much as possible.
Okay. That brings us to the end of the question and answer session. There are a few other questions that had come in. We'll endeavor to also send responses to some of the questions that have also come in and some of the questions that were put by attendees when registering. Thank you everyone for staying this long. I know it's smack in the middle of the day. We'll just call on Mrs. Okorocha to give a few words to close the webinar.
Yeah. Wow. It's been a really engaging discussion. I mean, my notebook is full of comments, you know, from the speakers and panelists, and I'm just so delighted with the breadth of knowledge and experience that has been on display here today. I want to particularly thank Dr. Kuti. Even though he had a conflict, he still found time to be here to give his keynote address. We're very grateful, Dr. Kuti, and thank you. I want to thank Dr. Onakoya. Thank you so much. Your expertise is second to none. We're very grateful to have you in our circle, and thank you so much for your contributions here today. Thank you so much, Njide Ndili. Thank you for wearing two hats today and bringing your over 20 years worth of experience, both as PharmAccess country director, as well as the president of the Healthcare Federation of Nigeria. Indeed, I was going to, if I were going to ask any question, it would have been to ask you what role, if any, the HFN can play in this situation. So I was expecting that question from you, Toby, but it didn't come. So we will have other webinars where we will explore. Dr. Olayemi Daudu, again, thank you so much for being here. I thoroughly enjoyed your contributions on how Lancet is navigating this space in Nigeria. The diagnostic space, the use of IT. I learned about receivers and what was it? Refusers and loggers today for the first time. So thank you so much. And of course, our very own Toyosi Odumbaku. Thank you for your expertise, your experience, which we totally appreciate. And I'm sure all our clients in the health and pharma space appreciate it too. And Toby, thank you for moderating so expertly today and navigating the conversations so successfully. Thank you to our attendees and participants, almost 200 here strong. Thank you so much for being here, sharing your morning and indeed afternoon with us for these important discussions. We are sorry we couldn't get to all the questions, but please rest assured, if you send them in by email, we probably will be able to send them to, I'm sure our speakers and panelists will agree to respond to them via email hereafter. So on behalf of Jackson, Etti Edu, I want to say a huge thank you to everybody here today and do have a pleasant afternoon.
Goodbye.
Thank you.
Thank you for having us.
Thank you.
Thank you.
Dr. Onakoya.
Bye-bye.
Thank you.
Bye.